interested in doing a copy of AZT. But because of the royalty fees, they will end up paying Glaxo the whole bunch of money, because they're also not, they also want, profit too, because they also driven by profit. But if it's affordable with profit, I think that's better than non-affordable with profit. And we won that case.
What we realized in around 2002, 2003, when we were looking at strategies to challenge profiteering and excessive pricing of medicines, we realized that the Competition Commission could be a useful forum into which to bring human rights arguments and into which to bring the rights that are entrenched in our Constitution. So we looked at the drug companies. We saw that we had a problem because you have a handful of big companies which dominate the market. We picked on two particular companies, GlaxoSmithKline and Boehringer Ingelheim, and gathered a lot of economic evidence, a lot of medical evidence, found complainants such as Hazel Tao, people who were living with HIV, who needed antiretroviral medicines, and way back in 2002, it was a very different environment to now, because now you can get antiretroviral medicines at any public hospital or clinic. Then you couldn't get it. And we went to the Competition Commission and said, look, in relation to the following medicines, these companies are abusing their market dominance. They're violating the Constitution because they're setting prices that have no relationship to the actual costs of these medicines.
Really going through my documents to be a complainant, I was very impatient, very angry to understand that where the companies are coming from, and how much do they make, and how much do they cost. It was like a frustration after frustration, because we were thinking of they win, they lose, they win, they lose, or the company decided to go back. And the hope was like the company is not going back to America. They are going to stay here, but we have to have a way of making them to understand so well. But it was a long process, very stressful, but truly speaking, it was not like we were so excited. We were like, okay, yes, we settled the score, we will take this, but a lot of people were already dead. But we have to save the ones who were few, which were left like now.
Today, now, my treatment costs about 130 from 4,000. 8 years, it costs now 130. And if we did nothing, some people wouldn't be alive, including myself. Because a price of drug, it's not just a price, it's about a life. And each time you don't reduce that price, you deny one person a chance to live.
But patents don't just result in high prices. In the past few decades, we have shifted to a system where patent monopolies and the high prices they allow companies to charge have become the main source for funding research and development of new drugs. This means companies only invest in research if there is a lucrative market for the eventual product. According to the World Health Organization, this has led to a situation where 90% of total research is targeted at just 10% of the global disease burden. One adverse effect of this logic is that research on long-term treatments for chronic conditions have been prioritized over vaccines, which would prevent disease in the first place, but from which companies stand to make less profit. On the other hand, research for some diseases that affect the world's poor has been abandoned altogether. One of these diseases is tuberculosis. In South Africa, TB is by far the most common opportunistic infection and the biggest killer of people living with AIDS whose immune system is compromised by the HIV virus. Co-infection with HIV and TB makes treatment for both more complicated, as the drugs used for one can interfere with the other. Resistance is more likely, and diagnosing TB is more difficult in HIV-positive patients. Yet because of the current system, there has been very little incentive for pharmaceuticals to research new treatments and diagnostics that work for co-infected patients. Just when we seem to be turning the corner on HIV, this massive hole in research threatens to undermine the progress made so far.
in the current system, where research and development is financed through patents, through being able to charge high prices, if you cannot pay, you fall off the research agenda. So in the last few decades, where we've moved towards that system, where patents pay for the research and development, health needs of people in developing countries have almost disappeared from anybody's research and development priority list, and particularly for the tropical diseases such as African sleeping sickness or leishmaniasis, but also tuberculosis, even though a huge number of people suffer from these diseases. You think of tuberculosis, 1.7 million die each year of tuberculosis. Those are neglected diseases because in terms of market opportunities, these people do not exist.
So we are in Kailicha, which is a township 30 kilometers outside of Cape Town in South Africa. It's a big township, it's about 500,000 inhabitants, living in, I must say, very difficult circumstances in terms of poverty, but also in terms of disease burden, because we have high prevalence of HIV, 32% measured at maternity, and we have a very high incidence of TB as well. It's about 1,600 per 100,000, 4 times the emergency rate of WHO. My role is, I'm a medical doctor. I'm actually the medical coordinator for MSF in South Africa. And part of my time is to be a clinical doctor here in this clinic, where we started a long time ago, 7 years ago, the first antiretroviral program in South Africa. From the beginning, when we started fighting HIV, we knew that it was also altogether we had to fight TB. It was very obvious 10 years ago that TB was growing very fast. Because HIV, because when you are HIV positive, immunocompromised, your chance to not to get infected, but to go from infection to the disease are multiplied by 10. Now, a new challenge that we did anticipate is actually the emergence of resistant TB, so-called MDR or XDR TB. Emergence of resistant TB, I'm convinced, is pretty much linked to the co-infection. The co-infection rate in Kailicha is around 70%. It means that if you take your TB patient and you test them for HIV, you will find that 2/3 out of them are HIV positive. And the problem with TB patients that are co-infected is that probably they do a substantial number of relapse. It's very common to see patients who have done, patients who are co-infected with HIV, who have done 3, 4, even 5 TB episodes. Okay, so what happens is that there's a substantial number of relapse as suspected, and they are treated with the same drugs all the time. And we are facing inevitably the same phenomenon as I explained before, of an infectious disease, a bug exposed to the same drug in the long run. Those bugs are very clever, and the TB1 is certainly one of them, and they develop resistance with time. So mathematically, we will face more and more resistance. And that's what we see appearing nowadays. We have diagnosed in the 2 last year more than 250 cases of multi-drug resistant TB here in Kailicha.
Well, tuberculosis is a huge problem. 1.7 million people die each year, predominantly in the developing world. There is another huge problem is the co-infection. A lot of people who die from tuberculosis are HIV infected. We have old drugs that in many cases are not effective. We do not have good treatment to treat multi-drug resistant tuberculosis, and there is no treatment whatsoever for people who have extreme drug resistant tuberculosis.
I think companies are not interested in TB, to be honest. One, I think because it's not a rich man's disease. That's obvious. So therefore, it's not sexy enough for them. HIV might be a little bit sexy because yes, it is both rich and poor men's disease, or working class and middle class in disease. So therefore there might be interest there.
We are left for the moment with using old, toxic, ineffective drugs as second-line drugs that were abandoned actually. PIS, one of the second-line drugs, was invented in the 50s, just after streptomycin. Abandoned because too many side effects, nausea, vomiting, a lot of them, and poorly effective. And we have no other option to reuse it for second line. We are recycling old drugs because the new drug pipeline has been empty for a long time. We expect maybe the new successful drugs only by 2012, 2013. I think there's been their major strategic mistake done. And as a result, our outcomes for MDR TB patients, and certainly for XDR TB patients, are extremely poor. We have, for the co-infected one, less than 30% survival.
The patent system hasn't, however, just led to the neglect of research on certain diseases. The patent rush of recent decades has resulted in a minefield of intellectual property protections that often actively obstructs access to research on new compounds, with competing companies reluctant to share information that could one day make them a profit.
Pharmaceutical companies are answering to their shareholders, and they know very well that if one of their new compounds is identified as very effective for TB, it will be inevitably earmarked for TB, because if it's used widely for other disease, it will develop resistance around. So it will be almost inevitably earmarked for TB, like rifampicin and INH are earmarked for TB. So as a matter of fact, companies tend to avoid to either put money in a research for TB, either to have their drugs being tested, if they've already proven their drug was effective, being tested as an indication for TB, because it would mean for them losing some part of the market. So we have today's drugs that are suspected to be very effective for TB, moxifloxacin, linezolid, that are used for other indications, and we know that the company, the patent holder, are reluctant that those drugs become, that they were too much tested for TB, because they might become earmarked for TB.
Another huge problem is that we do not have easy-to-use diagnostic tools that we can use in the field at what's called a point of care. That gives us a reliable diagnosis. We're forced to use microscopy, which is a technique that was developed in the late 1800s. We miss 50% of the active cases with that technology, which leads to inappropriate treatment or no treatment at all. So there is a desperate need for an improved diagnostic kit.
Let alone medication, but diagnostics is the key thing for TB, because the diagnostics that we have do not pick up TB, even if it's not in the high levels. There's not too much evidence in the sputum, so it's difficult to diagnose. So therefore, technology has to move with time, because at that time when the technology or the diagnostics were developed, they were developed where there was no HIV. They were developed where there was TB. But now we need to develop diagnoses that are friendly to both infections.
Clearly that is not going to happen by putting out patents, because one of the specifications of such a diagnostic kit is that it will have to be very, very cheap. Otherwise we will not be able to use it in the developing world. Another problem is that with the development of these kinds of technologies, there are lots of intellectual property barriers. At the moment, people don't collaborate enough to develop these technologies. We think that the knowledge is actually there to make it happen, but there isn't a collaborative effort, because the current paradigm is to stay in your corner and keep it a secret, so to say, and patent things left and right, which hampers scientific progress in this field. So we're saying we need a system where collaboration is awarded, because there is a momentum today that is very different from a few years ago. There really is a global recognition that increased levels of intellectual property protection are not going to deliver, and that we need to shift to a different system of financing and a different way of priority setting.
I think the reality is we can no longer deal with HIV in isolation of TB. If we want to defeat or to stop